Dr. Munson, said, I want this building to be a great place for our global health conference to be hosted someday. So that was exciting that he was thinking about this event and the planning of that. We're proud that RIT has kind of risen to be the 10th largest private university in the United States now, with international campuses in Kosovo, Croatia, Dubai, and China, which makes us kind of uniquely positioned with such a big global footprint to have a presence in this global health space. And we're excited that there are some things coming. We're in the process of working through a new global public health minor, and then proceeded directly after that will be a process to get a global public health major in place here at RIT. And I've been really enjoying working on that process. And I think that will help this conference even grow more as we have more and more students on campus that are focused on that. You can see in the slide, we've got over 19,000 students now and 135,000 alumni spread all over the world, 100 different countries. We're pretty proud of this place, and it seems to be on a great trajectory and moving in an excellent direction. So let me introduce to you a guy who's been working super hard this year as the president of the Global Health Association. I'm not sure how he does all that he does besides being a biomedical sciences major and an ROTC member. He's also involved in some other organizations, but has done a great job leading this one. I'm excited that he was recently accepted into the Master of Public Health program at Cornell University, where he'll continue growing in this area, and then hopes to go on to medical school after that. So let me bring in Michael Healy, the president of the Global Health Association.
Hello. Thank you, John, for that intro. I want to talk to you guys about what our club is. So GHA, we are focused to increase awareness in health challenges faced by people throughout the interconnected planet. And we encourage our members to come up with innovative solutions that will benefit our global society. So with this, we have different events that are held throughout our semesters. So we have monthly events where we have speakers come in. We have movie screenings that can have panels. And we're also having different events that we end with this year that we'll talk about later. So we're having a health education event. And each year we also hold our annual conference, which we're doing now. And we also have our members have different volunteering opportunities throughout the semesters. I would like to introduce you to our team. So this is everyone here who helped us produce this conference today. So I'm very proud of our team and very excited for what you're about to see today. So big shout out to them. But now I'm going to move on to our next speaker. So it'll be Ava, our vice president. She'll talk to you about our conference today.
Hi, everyone. I'm Ava. So I just want to give you a brief overview of what our conference this year looks like. So this year we're focusing on stigma in healthcare. So we're going to cover the 4 main topics listed here: vulnerable populations, which includes a lot of populations that face more stigma in healthcare than others, medical ethics and end-of-life care, medical technology and disabilities, and stigmatization of mental health. And so I also invite you to visit our website throughout the conference. We have lots of information there about the conference and our other events, particularly our schedule and our speaker bios would be a great thing for you guys to touch on today. Good morning, everybody. My name is Shannon McKee, and I just want to go over a few tips for the conference and just how to handle Zoom and everything. So first of all, if you have any questions at all throughout the time, please feel free to direct message me on Zoom. My name is Shannon McKee. You'll find me there. And if you have any questions during the Q&A portion as well, you can drop your questions in the chat, and we will be consistently monitoring that to facilitate to our speakers throughout the day. And then just a few more reminders. Make sure to stay muted as a guest in this conference so there's no feedback. And once again, if you have any questions, drop those in the chat, and we will have 5-minute breaks built into the schedule to allow for rests or any bathroom breaks you may need. Next up, we have Abby, who's going to tell you a little bit more about the club. Good morning, everyone. My name is Abby. I wanted to speak a little bit on our social media handles. If you're interested in learning more about GHA or keeping up with the news on our future events, A great way to do so is by following us on our social media handles. On the slide listed, we have our Instagram and Facebook handles, so feel free to reach out to us this way with any questions you have or if you wanted to learn more about the club. Thank you.
All right, so thank you to the team. We also have Emma Tucker, who's not with us at the moment, that's helped out this year with the conference as well. Next, I'd like to welcome the Dean of the College of Health Sciences and Technology, Dr. Wong, who has been with us now for, this will be the second conference that he's been present for. He's been very, very supportive of the College of Health Sciences and Technology's growing presence in the global and public health space, and I'd like to welcome him to say a few words of introduction. Thank you for being with us, Dr. Wong.
Thank you, John. Good morning. Can you hear me? Good morning, everyone. I'm Untitled Wong, Dean of the College of Health Sciences and Technology at RIT. On behalf of the faculty, staff, and the students of the college, I would like to welcome you to the 4th Annual Innovations in Global Health Conference at RIT, and thank you for your participation. I would like to thank Dr. John Oliphant, Mr. Michael, Healy, Ava, Shana, Obi, and the team, co-worker, and the student for making this conference possible. And at RIT, President Manson and Dr. Jim Myers, Associate Provost for International Education and Program, and RIT Global Health Association are very supportive for global health engagement and promotion. Global health is about worldwide health improvement, reduction of disparities, and protection against the global threats, regardless of national borders. This global health conference will focus on several aspects, such as vulnerable population, medical ethics, and end-of-life care, medical technology, and disability and mental health. The goal of our conference is to bring awareness of the health challenges faced by people throughout our interconnected planet, and the challenge with our member to generate innovative solutions that will benefit our global society. As we know, that COVID-19 has affected the world in many ways. I hope this conference will guide us to deal with and to end how to end the COVID and similar pandemic more effectively in the future. In the College of Health Sciences and Technology at RIT, our academic programs are all related, health related. So we wanted to incorporate emerging technologies into health professions and bridge the gap between the education and the clinical practice. And right now, Dr. John Oliphant is in the leading role, develop a global public health program, BS program. And we also work on several doctor health professional programs, such as doctor physical therapy, occupational therapy doctor. So we're working with Rochester Regional Health and other local healthcare organizations to improve the local community health and beyond. So I would like to work with you and the world health professions to make a better and healthy world in the future. I wish you all a very successful conference, and thank you.
Thank you very much, Dr. Wong, for your comments and for your welcome. And it's a pleasure to have you in the leadership role you have in the college right now, and your support for the growth of global public health initiatives is greatly appreciated. Next, I'd like to welcome a good friend and colleague and mentor for me, Dr. James Myers is our Associate Provost for International Education and Global Programs. Dr. Myers has been very involved in work in Haiti and with our international campuses, and has just given me a lot of great guidance and insights as I've continued to move more and more into this space, and I'm forever grateful for that. He's also been a big supporter of the Global Health Association and specifically this conference over the years. One thing that, a kind of rough thing happened this year. For those of you who are familiar with leaders in global public health, we lost a gentleman named Dr. Paul Farmer. And it was interesting. I had just been showing a documentary about his life and work in my global health class when he passed away this year. And I understand that Dr. Myers had the opportunity to meet him and see him speak. So I'd like to welcome Dr. Myers, and perhaps he could say a little bit about, who the global health community lost this year as well.
Thank you, John. And I too want to thank the Global Health Association team and Professor Oliphant for the great work of continuing this conference and keeping global health issues at the forefront of people's minds. Of course, we've never been more, I think, probably thoughtful about our global interconnectedness through health in the time of COVID. I want to thank John too for giving me this opportunity. As John mentioned, I've worked in Haiti now for over almost 20 years. Before that, I've been involved with health projects in places like Niger and Kosovo and other places in Africa. And like many of us, we got introduced to Paul Farmer through Tracy Kidder's book, A Mountain Beyond Mountains, and which is really the story of how Paul and Jim Kim, Dr. Kim was the president of the World Bank, and is somebody who is also incredibly inspiring. If you have a chance to look him up, he was president of Dartmouth and president of the World Bank, and together they founded an organization called Partners in Health. My mentor in life was a woman by the name of Rosemary, who was a Haitian American. Her family was from Port-au-Prince. Her father was an agronomist, and they fled Haiti during the Duvalier era, which was a really difficult time in Haiti, and they established themselves quite successfully in the United States. And Rosemary became a professor of anthropology and head of the department at Geneseo. And she founded an organization that I've been on the board of now for, like I said, almost 20 years, which is Haiti Outreach Projet Espoir. And the model that organization works on was inspired by conversations that Rosemary and Paul Farmer had together while they were working on their PhD dissertations together. Many people know Dr. Farmer as an accomplished physician, and he is, or was. But he was also an incredible anthropologist, and he had a PhD in anthropology, and he really understood how culture and history and context matters in terms of dealing with public health issues. He's written some amazing books. I would gladly provide a reading list for anybody who wants to read them. One of my favorites is a book called The Uses of Haiti, which is a story really about how Haiti has been a focus of colonial powers, and particularly a staunch critique, really, of American policy towards Haiti and across time. And so he was not only a really brilliant physician, but he was a great anthropologist, and even probably a more incredible philosopher in a lot of ways. So I was just enamored with this guy, and Rosemary and he had become very, very good friends. And so on the at least 3 occasions, I had a chance to sit with him, usually after a talk. We went to Boston to see him. He spoke at Canisius College, and we went there to see him, and I had seen him speak at a USAID conference, sponsored conference in Washington, D.C. And both times he was gracious enough to meet both Rosemary and I afterwards, and usually over a long period of time, hanging out, talk about sort of the state of the world in healthcare. And just to give you a sense of what he was able to achieve, this was a man who committed himself to delivering healthcare to the poorest of the poor in the most difficult situations. The hospital that he opened in Haiti is in a town called Kanj, which is in the high plateau, middle part of Haiti, very, very isolated part of Haiti. He did this while he was in medical school, by the way, and then proceeded to sort of open up this partnership idea around the globe. Just a quick sort of 2 things that stand out in my mind as things that he contributed to the way in which we now think about healthcare to the poorest people. One is to essentially make it free for those who can't afford it, that ethos, and to bring it to them at a high quality level is absolutely a model that had not been done until Paul Farmer did it. I would say the second thing, and this isn't talked about very much, but he and Jim Kim discovered an outbreak of tuberculosis that was basically being lied about by the Peruvian government in the barrios of Peru in Lima. The challenge, of course, with tuberculosis is that you end up with having a drug-resistant variant of tuberculosis if people don't complete their full regimen of prescription antibiotics. And the common argument was that we couldn't do what's called a direct observation therapy approach to this because it was too costly, particularly for this particular population of people. Partners in Health went about doing that. They implemented a direct observation therapy protocol, which basically means for the entire regimen, which can be 30 to 60 days of penicillin or antibiotic treatment for tuberculosis, that somebody actually watches the person, delivers and watches the person take the drug, and follows up with those who don't show up for their appointments, or even better, goes door to door and makes sure that they get it. This was argued that this was too expensive. They proved people wrong. They went about doing it and saw dramatic reductions. And direct observation therapy, which was long sort of poo-pooed by the by the established health community, has been accepted as a way of doing it now. Sort of the universal way of dealing with these kinds of major outbreaks with potential drug resistance problems. I think the second thing, and this is a huge accomplishment, was his moral suasion of the pharmaceutical companies to lower the cost of antiretroviral drugs. The profit margins in the early outbreaks of earliest days of HIV, AIDS, and the discovery of ARVs and the effectiveness of ARVs, which is the only treatment that there is for HIV, AIDS, was really quite shameful. Paul worked so hard to change that and to lower the cost and to get governments involved around the world to really pressure the pharmaceutical companies and also to the governments to lower those costs and make them affordable so that people around the world would receive those treatments, particularly in Africa. He ended up spending the end of his life, much of his life, the end of his life in Rwanda, where he had an equally powerful effect on Africa and the HIV/AIDS situation there. And I think that most notably that the effect of getting ARVs available there at a reasonable cost. He was the kind of person who, after 2 hours of talking, would stand around and never left until everyone got a chance to talk to him if they wanted to. When we went to Canisius to see him, we were there at, I think the talk started at like 7:30 or something like that. He spoke for about an hour and a half. It was 9 o'clock. it was 10:30, almost 11, and probably 10:45 before the auditorium emptied out, because he would stand and shake everybody's hands, and anybody who wanted to say hello to him or talk to him, he would wait for. He had no arrogance about him whatsoever. He was the most humble, kind, generous, loving person that I, quite frankly, may have ever met. So we did lose an icon this year, somebody who was incredibly impactful on the world stage, but who was really just an extraordinary human being who offered up a lot of inspiration. So I don't know how you all feel about this, but I would appreciate maybe just a moment of silence in honor of this person. We'll take just like 30 seconds or so and start the conference after we do that. Thank you so much, John, for asking me to do this. It's very flattering, and I'm truly humbled to be asked. Thank you very much.
Thank you, Dr. Myers, for that. And I think the moment of silence is completely appropriate. I would encourage anybody who would like to know more about this gentleman. There's several books, as was mentioned, but there's also a great documentary on Netflix called Bending the Arc that is super powerful. Just make sure you have a box of tissues handy, because you probably will be moved to tears a few times throughout the documentary. All right. Well, I want to introduce a friend and colleague as well, whose work inspires me greatly. Mary Golden is an associate professor here, and she's the director of the Bachelor of Fine Arts program in interior design. And I know when I initially thought about interior design, I wouldn't have made a natural connection to global health, but Mary has really connected those two worlds in a big way. She's got her students very involved in making an impact around the world, and has come up with some really creative programs that are making a difference in particularly in Honduras, where she's worked on some things that I know she'll be telling us about momentarily. Again, if you go to our website, there's a place for speaker bios. I would encourage you to read about each of our speakers in more detail, but for time's sake, I'm going to let Mary go ahead and get started with her presentation. So Mary, we're so glad to have you back with us to kick things off as our first big speaker.
Thank you, John, so much. I really appreciate that. I'm going to share my screen here. I really appreciate the invitation, and much thanks to you and to the students for inviting me to speak today. I'm here today to talk with all of you about a nice project that we've been working on in interior design and through a multidisciplinary effort. And our efforts have expanded across the college. We started in interior design, and we've involved students from healthcare areas, from engineering, and also from industrial design and graphic design. So the project that I'm talking about today is our prototype neonatal ambulance that is designed to serve the country's most poorest and vulnerable population, neonatal critically ill babies in the country of Honduras. And our concept that you can see here makes relevant the transport practices and the road conditions of Honduras, which vary very widely. And the goal is that this is an easily maintainable and repairable vehicle that's familiar to the people of the country, and it's properly outfitted. And I think both John and Jim just gave a really great synopsis of this idea of being able to provide free medical care to those who need it the most and are in the greatest need. So RIT will be donating this ambulance to the Red Cross in Honduras.
Recording in progress.
So RIT will be donating this ambulance to the Cruz Roja Hondureña, or the Red Cross in Honduras. That will be happening in just a few months, and this will serve in the main city of Tegucigalpa and surrounding region. So just to give a little bit of context as to where we are, here we are in Rochester, New York. Honduras is a Central American country. Interestingly enough, there's 2 population centers within Honduras. Tegucigalpa is the capital of the country, and San Pedro Sula is the industrial capital, both of them really burgeoning close to 1 million people. We're seeing about a 2.6% rise every year in population growth. So this is very impactful in terms of healthcare and access to good healthcare. And you'll see that in just a few moments as to why this is so important. Most of the residents live in the western half of the country, which is a very mountainous region between Tegucigalpa and San Pedro Sula. A little bit of background information. We do track through the RIT Hope for Honduras project and our project partners both in country and in the United States, the poverty rates and exactly where are we. There are only 2 specialized neonatal intensive care units in the country. Hospital Escuela is the largest public hospital, and that is in the city center of Tegucigalpa. Hospital Mario Catarino Rivas is in San Pedro Sula, and that it also has a NICU. The way that healthcare is tiered in the country is that a level 3 is a major hospital with a NICU. Underneath that is a rural and regional hospital, and below that would be the healthcare clinics that most women would go to for prenatal care and postnatal care. So the mortality rate has been dropping about 2.6% each year as well. We've been tracking this really since 2013. 2016 is about the time that I started to get involved very deeply with the project, and at that time it was 17 deaths per year. Last year, 13.5 is what we were looking at. Between the 2 hospitals, 60% of the neonatal deaths are accounted for in the country, and that's primarily because those are the NICUs where they have the intensive care units. Currently, and why we're having this discussion today is that there is no formalized ambulance system in the country that supports neonatal transport between rural hospitals to the major hospitals or even within the communities. This is Hospital Escuela in Tegucigalpa. It is the largest public hospital in the country. It was built in 1969, and it was designed to accommodate 6,700 births per year. And as of 2016, they were accommodating 16,000. And that number has been increasing annually along with the population rate. So the hospital is grossly undersized for the amount of babies that it is handling per year. So in the high season of births, as we know, births tend to rise and fall across the year. This is what that hospital looks like. Their birthing rooms essentially overflow. We have women giving birth in the hallways, and that's also some of the same areas where aftercare birth is provided. You can see that the receiving areas are overloaded. Babies are sharing bassinets, which creates a lot of bacterial infections. So a lot of babies actually don't even make it upstairs to the NICU. So the babies actually have to wait if they need intensive care in this space, postpartum space. And the doctors have the really difficult task when a space does open up in the NICU upstairs of coming down and selecting the infant that they think they can, most likely save. So it's a heart-wrenching and heartbreaking situation. And so when we look at this in terms of neonatal transport and access to medical care, we not only have the impact of those very high numbers and compression of space and facilities at Hospital Escuela, but we're also bringing babies in from the regional hospitals. So Hospital Santa Teresa in Comiago, which is about an hour and a half away, will transport a few babies maybe every couple of days down to Tegucigalpa that need intensive care. So those babies are making quite a long drive along a highway. Now, one of the pluses is that there's been a lot of infrastructure changes in the country in the last 5 years, and this major highway CA5 has actually been completely refurbished. So this is actually a really great transport route now. It's really just a matter of getting the correct kind of ambulance system. So back in 2017, when I took a trip to Honduras, my initial trip, we did have the opportunity to go from Hospital Escuela up to Hospital Santa Teresa, and we were taking a look at some of the ambulance systems, and this is their ambulance that they have. If we take a look inside the ambulance, it's really quite grave. This is a vehicle which transports not only neonates, but cancer patients, somebody who may have been in an accident. Whoever needs care at the major hospital is basically put within this vehicle, and babies are oftentimes traveling in a bassinet, and unfortunately don't often make the journey to Hospital Escuela for that life-saving care that they really need. So at that time, I was traveling with the Little Angels of Honduras, Christian Piri on our left here, Katie Piri in center, and Dr. Alejandro Young of Hospital Escuela. I was brought into this project very interestingly. I taught at Alfred State prior to coming to RIT, and Christian was an architecture student there. And he had been in Honduras on a Christian mission and was exposed to these challenging conditions of the hospital, and has really made it his life's work to help Dr. Alejandro reduce infant mortality in the country of Honduras. He and I stayed in touch, and when I got to RIT, I said, you know, I'm in this really interesting place, and I'd really like to be able to help you. Let's see what we can do. And that became the genesis of RIT Hope for Honduras. And little did I know that we would start this multidisciplinary collaboration across campus with an explosion of projects. So the projects originally started in the interior design program to help Christian out with his design for 4,200 square feet of addition to Hospital Escuela and the NICU to provide additional incubators and training for not only mothers with skin-to-skin contact, but training also for doctors. So we had 20 interior design students provide design scenarios to give support to Christian's mission to get $250,000 to do this addition. On one of our trips to Honduras, we presented this to the Ministry of Health, and the Ministry of Health said, we love it, but we want more. So we now have a shovel-ready project of 12,500 square feet with a complete renovation to the existing NICU and a double of square feet for an entire new 6th floor. We're anticipating that this renovation and addition will save approximately 600 babies per year, in addition to those who are already being saved. So this will have a fully modernized benefit to the country. So BEAD and the World Bank are supporting this. So right now we have all the money that we need to build the hospital and to outfit it with medical equipment. So what's really left is actually the interior design package. And so we'll be doing some fundraising around that for about $250,000 to $300,000. This project, as we started to look at the expansion of the hospital, we realized that it was really only one component to providing better access to medical care. We really needed to look more holistically at the needs of the country and the needs of really the women and the babies in the country. So that started to spawn all of the projects that became RIT Hope for Honduras. So in addition to projects like you're seeing in the bottom left and right, mobile education units and pre-me examination tables, we involved graphic designers who actually started to put together pamphlets and information and educational information. Our industrial design program designed pre-me wraps, which have the name Abracito. This is a line of soft goods that will serve mothers and infants in the process of skin-to-skin incubation. And then, of course, the problem that we're here to talk about today, which is better access to medical care. And so we are looking at really the terrain of the country and how challenging is it to get babies from one location to another. So you can see here the great diversity from a typically paved road that we'd find in Tegucigalpa to more rural roads in San Pedro Sula to the mountainous terrain of the country. So we charged a team of multidisciplinary students in their capstone senior year from engineering students that were in biomedical engineering, sorry, let me back up. There we go. I'll just keep it here for just a moment. So our multidisciplinary team of students from biomedical engineering, industrial design, electrical engineering, mechanical engineering, interior design. These students did not know each other when they first started, and they came together as a team to explore this problem together over a 2-semester course. The 2-semester course had various phases. Phase 1, 2, 3, and 4 essentially went through the project from a design concept phase, and then 5 through 8 was building out a full-scale prototype. We did bring the students to Honduras on a mission trip, and I want to thank Jim Myers for helping me champion this. It was quite a challenge to organize this, and we took 5 students from each of the different design teams down to Honduras and for a 3-day quick trip. Try to go back to full screen here. So with that, the students actually engaged in some deep research involving ambulance design and what were the existing conditions. This particular ambulance was from a private hospital, which has a lot more money than, say, the public hospital. So Hospital Escuela and Hospital Santa Teresa, they serve the country's poorest. And so all of those services are free to the community versus a private hospital, which is actually where people are paying into this. You can see that the ambulance inside is somewhat similar, although more upscale a little bit in terms of the interior finishes and materials. It's a little bit newer, but essentially very basic vehicle. So the students actually did a full analysis in terms of dimensioning, thinking about the mechanical and electrical needs that would go in, as well as the ergonomics. You can see it's a really tight fit here. The students also were able to interview drivers, and what was really interesting about this is that we learned from our drivers that they're not trained medical professionals. They are essentially folks who have a regular driving license and a license for heavier vehicles. They don't use a GPS. They essentially are traveling through the village and the city because they know the area. And they'll make about 12 to 15 trips a day. And there's typically 4 to 5 different drivers who are basically on call. So these folks are under incredible stress. And as you can recall, there's really no division between the medical space and the driver space. So they're navigating really challenging driving conditions in the country, as well as what's going on in the back of the vehicle. So this started to give us some criteria by which to design, and essentially we determined that the experiential moments for both the driver, perhaps a family member, providers, and the infant was the most important. And we really came up with this whole series of elements that the interior should complement to the medical and life-saving faculties of the vehicle. We settled on a Land Cruiser 78 hardtop because that was the vehicle that's most familiar to those in Honduras. There are parts that are available and dealerships that can repair the vehicle. It's also a vehicle which is known globally across the world. And the idea with this is that we will be able to scale this over time, and that this neonatal ambulance will be able to go global. So the students embarked on a design process, and this was their final iteration, really looking at getting 2 infants into the back, a paramedic, or provider with specialized storage systems and all of the medical equipment. So the students actually went through the process of designing out all of the storage from the tactile experience of the provider. We did work with John's team, which was really great, and some of the PA students who went through the mechanics of a well baby examination, and we learned about all the tools that needed to go into the vehicle and right-sized all the storage equipment. In tandem with this, our electrical engineer was looking at all of the systems and mechanical and medical equipment that would need to go into the vehicle and designed out that system. Our biomedical engineers were selecting out all of the equipment that would need to go in. Our students engaged in that full-scale prototype, and I think as John mentioned, we have the shed coming up, which would be a space where something like this hopefully in the future would be designed and built. Here we're in the elevator lobby in between interior design and industrial design, which became our home base for building out the prototype and for getting together for Hope for Honduras. It gave us a great opportunity for other classes to come in and for the students to actually take part in an ergonomics test where they looked at reach ranges, lines of sight, and comfortability. In 2018, I think it was April, Ted Van Horn, who is the Chief Operating Officer for Global Medical Response, was on campus for a reunion of the RIT ambulance. And we were introduced. I think it was Linda Miller and Lisa Bazzatoro who introduced me to Ted and said, you know, let's have him take a look at your project. And that was really a magical and serendipitous moment. The students talked with Ted, and he was on board right from that moment and has become a huge benefactor of the project. So he sent out the Global Medical Response team. They brought out one of the local ambulances. That gave the students a lot of insight into the working faculties of the ambulance and all the needs of the provider as well as the patients. The students finished out that cardboard mock-up that you saw at the beginning here, dressed it out for Imagine RIT, which was their goal as students. We took this down to New York City Design Week, and we were awarded recognition by Metropolis magazine for being one of the best moments of Design Week. So moving forward into 2018, 2019, traveling down to Honduras, you know, the journey map of this between 2018 and 2021 becomes a lot of logistics. We got a lot of support from the Ministry of Health for the infrastructure of setting up this ambulance system. I met with the First Lady of Honduras, who also gave us a lot of support. During this time, 2018, 2019, there was an ambulance system introduced into Honduras, a 911. They got 18 ambulances donated from the country of Korea. And this is a free service, and it's only in the city of Tegucigalpa as a pilot program, but it still does not have a neonatal ambulance. Linda Miller and I traveled down to Global Medical Response Next Fleet, which is their outfit facility, to visit Ted and his team and to start talk logistics about how we might be able to build this prototype out and realize it. It's an amazing facility. They produce an ambulance a day. So it really seemed quite viable to get our vehicle done. Over the course of that time, we were figuring out how do we bring a vehicle that the EPA does not approve into our country? How do we get it back out? Who owns it? Where does all this money come from? And then, you know, how do we organize this? So this is our vehicle, which arrived in late summer of 2019 to AMR's Next Fleet operation. And in December of 2019, we really thought we were going to be good to go, and I traveled down to Next Fleet so that we could start to lay out the vehicle and work from the student plans that we had. Between the time that the team graduated from RIT and this moment where I am at GMR, we actually did revisions to the student drawings. Alexa Boyd was the interior designer, stayed on, and she and I essentially volunteered our time together to bring those drawings up to a design development set so that the team at GMR would be able to go through and to start working from those design development drawings. So we went through and started to lay out the vehicle, assessed medical equipment. This is Ken Thom here in the center. Ken is the director of the operations there at Next Fleet and has been incredibly instrumental in making sure that this vehicle was made at an extremely high level of quality and as efficiently as possible. So we ran into a lot of challenges during this period of time where there were a lot of shipping delays that put our vehicle into a little bit of a delayed status. But there were still some really amazing serendipitous things that happened. This is Tim Schroeder from Ace Tech. He happened to be there in December while I was visiting, heard about the project, donated a solar panel from Ace Tech, and also a geo-tracking system. So the amount of generosity with this project has just been really incredible. This is Anthony Perez. He and I worked together over the course of a year, hardcore 6 months of figuring out the exterior decaling of the vehicle. Interestingly enough, color plays a huge role in decaling and the safe transport of this vehicle in country and safe use. So many colors are associated with government or gangs. There are 13 different colors that we could not use, and interestingly enough, the RIT colors were the ones that we wound up using because they were a neutral color, so it worked out really great for us and for the Red Cross. During this period of time, we not only did we have shipping challenges, but we had COVID-19, there were West Coast fires, dengue fever, hurricanes. All of these things took a huge toll on all of us. Both the Red Cross and the folks at GMR were deployed constantly to address these. So it really wasn't until July that we were really able to get back onto designing the vehicle. This is a kind of a rapid compilation of all of the activities down at GMR over the course of time. Back in December, we stripped the vehicle down, started getting it ready to go, figured out all the logistics. Started really looking at the challenges of trying to put a full-size ambulance into such a tiny space. You can see the head wall going in there in the back. To really explore the student design, we started to make mock-ups out of plywood and recreate the vehicle on the ground to make sure that we were going to be able to get the pods to fit inside. The pods are our transport unit. The vehicle was then fabricated, and as you can see here, GMR has the full equipment to realize out the vehicle. That was our bench seating and also the benches that would support the pods. Putting in the exoskeleton to support the storage systems. The head wall is going in the back. Took quite a while to get our electrical and mechanical systems loaded in under those benches. We had worked with the Red Cross over the course of that kind of down year to figure out exactly what was optimized. And we decided that 2 providers in the back would be the most important. So we did reconfigure the vehicle to allow for 2 babies and 2 providers. Here we are at the paint shop. GMR has the capabilities of bringing the vehicle into the paint area and painting the entire vehicle as well as all the components. In addition to that, they have their own upholstery fabrication area, so everything was designed out and completed, the interior outfitted with flooring material. Here we see the decaling getting going. And in just a minute here, we'll see our vehicle come to fruition quite quickly. And there we are, fully outfitted, ready to go, baby pods in place, team readying the vehicle for a photo shoot. And there we go. So this is our vehicle. Today we're really ready to launch this vehicle into Honduras. We'll take a quick tour through the center here. This is the interior of the vehicle. You can see it fully outfitted with the benching system. Again, all of the electrical mechanical is hidden underneath. We brought heating and cooling into the back for good air filtration. These are the baby pods. These are designed and produced by Advanced Healthcare Technologies based out of London. Interestingly, these products, are designed by folks who design race cars. And these pods are typically used in helicopters. Essentially, it becomes an isolation type pod where the baby is completely secured in place so that it can take the jostling and movement that some of these terrains may impart on the vehicle. So in addition to that, we included a micro refrigeration system to hold medication. This is a great shot here too of the benching system that was designed, custom designed by Alexa and myself and refined by the GMR team to secure those baby pods in place. It's a very typical buckle down situation like you would have with a regular stretcher. You can see our head wall there fully dressed out with our medical equipment, our monitors, and our gases. What's great about this is that we do have connectivity with the driver in the front, but it is a closed scenario, so the driver is able to concentrate on the road conditions, and if there is a family member, they are somewhat separated from some of the challenges that may be happening in the back. We also have the Inferno System here. The Inferno System is showing the attachment here, which is essentially a pouch mount plate, and these are demountable so that the provider can actually take down the equipment that they need, easy to restock and refill. There's additional electric in the vehicle so that, see, I'm frozen here for a second. Okay, so that if anything else needs to be added, what's really great about the Inferno product that we used, this is some of the deviations that we made from the original student design. The student design was essentially a custom-built case good. We went with the Inferno product because it allowed for the most flexibility. We're able to move these pouches around. We're able to move equipment around to accommodate whatever the needs are for that particular transport or for the particular providers that are in the back, and it provides a lot of flexibility over time. We had a huge amount of equipment and supplies to get into this vehicle, and every micro bit counted. And so we used every square inch creatively, hid things like trash and waste under the seat. The provider seat next to it allows for additional storage systems. There is seat belts for the providers. I'm showing this image with both Ted and Ken in this vehicle to give a sensibility of, even though it is an incredibly compact space, Ted is about a foot taller than me, and Ken is even taller. So you can see that these gentlemen actually fit in the space pretty comfortably. Ken's demonstrating the reach range, which is great. One of the things that we did not do that the students had suggested was to raise the roof. Originally, the student design raised the roof from 48 inches to 60 inches. It just proved to be so much more expensive to raise the roof on the vehicle, and we were really trying to look at how can we create an economical outfit of this vehicle that we can reproduce very easily. So that was one of the major changes, but you can see people here are pretty comfortable. This is Alexa several years later, very proud to be in a vehicle that she contributed heavily to. Our solar panel in place. We also beefed up the suspension of the vehicle so that it could take those off-road conditions, and we did have a little bit of fun testing the vehicle out at the facility at GMR Next Fleet. Yes, that is me driving. So we had a really nice beta test. One of the things that we are looking at is not only looking at how the vehicle is performing in off-road conditions, but using the geo-tracking system to see what we are capable of tracking on this vehicle. ACETEC gave us a really robust system. And that system typically is able to track everything from gas mileage to whether the driver is wearing their seatbelt. We're going to be able to watch the vehicle in real-time travel and be able to look at some of the areas that the vehicle is going in most frequently. And that will also help us to identify where some of the areas that additional care may be needed in, maybe additional prenatal care, so we can start to look at those clinics and provide additional information. So one of the things, once this vehicle gets on the ground in Honduras, I will be able to track this on a daily basis. So we're in conversation right now with the Cruz Roja Hondureña and Hospital Escuela to look at longitudinal studies on baby wellness. How many babies are we saving? What is the provision of care? How well is the vehicle performing as designed? And what alterations do we need to make? So I'm really proud to say that our customs documentation is in translation, and we should have that back by the end of the week. Once we get through customs documentation, it should take us about 2 weeks to get the vehicle to Honduras. It'll travel from Houston, Texas to Puerto Cortes, and then it'll make the 6-hour drive from Puerto Cortes to the city of Tegucigalpa, where Cruz Roja Hondureña is. It will service that entire blue area around Tegucigalpa and also the test pilot route out to Comayagua. So again, we're super excited. There's just been so many wonderful people involved in this project, and we're incredibly grateful to all of our partners. For those of you who are interested, there is a YouTube video that is really quite sweet. I do suggest that you take a look at that. And this is a list of our partners, and I just want to thank also Linda Miller, who is the Executive Director for Presidential Advancement here at the RIT. And she's just been instrumental, as well as Ted Van Horn, just amazing generosity from his family foundation and from all of our sponsors. And our GMR team, many hands at play on this lovely little vehicle. And of course, a shout out to our film and photo team. So I want to thank everybody today for taking the time to listen to our project and my talk. If you'd like to reach out to me, this is my contact information. So thank you.
Hey, Mary, thank you so much for that great talk. I don't know if you saw, there is a question for you in the chat. Did you see that?
I did not see that.
Shannon, do you want to go ahead and read that question?
Hi, Mary. The question for you in the chat is, will you be accepting students and other volunteers for future trips to Honduras, such as public health students?
I would love to. In fact, we have a memorandum of understanding with UNITEC, which is a medical school in Honduras, and we all have memorandums of understanding with the Cruz Roja Hondureña. Some of the things that we'll be looking at would be students from RIT, both in design, healthcare, et cetera, working with students and faculty from UNITEC. And there is conversation right now about having involvement on the ambulance with our teams. So stay in touch with me. That would be great.
All right. Thanks, Mary. I think that your presentation to me is so encouraging because I feel like RIT has so many amazing resources that can make a real difference in the world. And I feel like your project pulled a lot of those different things together along with stuff in the community and around the world to really make a difference. So I think it's kind of a great trailblazing, precedent-setting project that hopefully can be the first of many of its kind. So thank you very much. If anybody has additional questions, please email them to us and we'll make sure we connect you with Mary so that you can get those answered. So thank you again. I wish we could all applaud for you, but you wouldn't hear it. So thank you very much.
Thank you.
So I think we're having a little technical glitch with the person who is on the schedule to speak second. We're going to hopefully get Dr. Mcginnis back, but I think we're going to move on to our next speaker, who is Dr. Samantha Sassone. She's a nurse practitioner who is an assistant professor in the School of Nursing at Lemoyne College over in Syracuse, New York. And she's going to be talking to us today about how medical and public health research supports the ongoing need for health promotion in meeting menstrual hygiene needs. And then after her presentation, we're going to mention a way that the RIT and surrounding community could help in that very thing. We have an event coming up that's related to that. So thank you, Dr. Sassone, for being flexible and jumping in here and keeping us moving.
Absolutely. Good morning, everyone. It's nice to be with you this morning. I am going to go ahead and share my slide deck. Hopefully everyone can see it. Host disabled participant screen sharing.
You should be able to share now.
Okay, perfect. Sorry about that. Can everybody see these okay? All right, so my project looked at reusable sanitary napkins in rural India, and I did a quality improvement project with adolescent girls living in rural India and Tamil Nadu in southern India. So the vulnerable population that I really explored was adolescent females. I looked at the implications of access to healthcare, the caste system, the dowry, exchange for money for females, and the socioeconomic impact that it has on managing menstruation and an ability to attend school. So when I was looking at awareness for menstruation in India, there is definitely low awareness. So in India, there is no sexual education, there is no physical education on menstruation, and this leads to early school dropout. And the three main reasons that students drop out of school is lack of sanitary napkins, lack of functional toilets, and low awareness of menstruation. So when I did my initial lit review and search, the four emerging themes were menstrual hygiene management and effects of girls, wash influences, which is water, sanitation and health, female reproductive infections linked to poor hygiene, and accessibility to latrines and need for better hygiene options. So the population that I worked with, I would say approximately 50% of the adolescent girls that I worked with when I went there had no idea what menstruation was. They thought that it was a punishment from God. There was no indoor plumbing or facilities for the girls to use when they attended school. So most of them were unable to attend 3 to 5 days a week, depending on when their cycle fell. And it was reported in the communities that I worked in during the evening, if the girls had to urinate or defecate and they didn't have plumbing in their homes, that they were repeatedly sexually assaulted when they were trying to find a place to go to the bathroom. So when I was at a previous institution, I led 2 short-term study abroad trips to India. So I've actually been in this area. I've worked with the population. I've been in the schools, the healthcare system, and the community. And these are fabulous young ladies. And it really got my wheels spinning in a sense that, what can I do? How can I look at this situation? How can I bring awareness to this? And how can I mitigate some of these risks for them to stay in school, to have physical, emotional, and mental stability and safety? And this is kind of where my project came from. So my quality improvement project was to improve the health and well-being of adolescent girls in rural Tamil Nadu, India, by implementing an evidence-based menstrual hygiene management education program on feminine hygiene care and providing access to reusable sanitary napkins. The 4 aims of my project were to improve knowledge, to increase adaptation of reusable products, to decrease the percent of school days missed due to menstruation, and increase menstrual practice needs met. So when I was enrolled in my doctoral program at Duke, of course, COVID-19 hit and I had to transition. So going to India and running my study was no longer feasible. So I ended up having to transition to an intercontinental collaboration with a partnering NGO in India. One of the hurdles that I had to jump was shipping all my materials to India during the pandemic. And if any of you have ever worked with the Indian mail system, you know how frustrating that could be. My whole entire project was held up in customs for about 3 weeks. And that was really anxiety provoking, not knowing if all my hard work was going to get there. Education on menstrual hygiene management, I had to reformat it. Originally, I was going to do in-person education, and I switched over to pre-recorded PowerPoints for the participants to listen to. And then my NGO partner had to collect my data, so my pre and post. They had to distribute my menstrual hygiene kits and bring the technology into rural poor communities for me. So when I look at my project methods, you will see down on the right-hand side of your screen, these are actually the menstrual hygiene management kits. I actually created them. I made them myself, along with the assistance of my grandmother. She's a master seamstress. Her nickname is Gigi for great grandma. And so Gigi and I sewed 250 reusable sanitary napkins, and we fashioned these privacy drying shields. And there is a method to the madness. So they are wicking material with cotton, and then the wings on the pads double as toilet paper because toilet paper is not readily available for my sample population. So the larger one in the back, the blue, that's the overnight design with the 4 layers. And the other 4 have 3-layer design, and they are made for everyday use. And then we have this, what I coined the privacy drying shield. It's a fabric mesh pinny. And what happens is when girls do use reusable rags or old pieces of clothing or whatever they have access to during menstruation, you can't openly menstruate in India. It's very taboo because of the cultural piece to it. Some of my participants during menstruation, their fathers do not let them stay in the home, and they actually have to sleep out in the barns with livestock. So, washing your menstruation kits and hanging things on the drying line is unacceptable. So a lot of times the participants would stick them under their bed or in the back of the closet. And with this dark area, it was more prone to infection, fungal, different types of bacterial vaginosis. They were more inclined to get it. So this privacy drying shield allows them to wash their pads, put it inside, and then hang it in a closet on the line for privacy. So my intervention was these menstrual hygiene kits and also the pre-recorded education. When I looked at it, it was over a 120-day period. It was broken into 2 phases. Phase 1 was participant recruitment. So I worked with an Agarwali, and that is a name, Indian name for a community health worker. Her name was Ambali Alex. And so she had already been in the local communities of Trichy and Trivandamai, and she had participants that she knew that would be fit the inclusion criteria for my study. So we had open enrollment from December to January. Once the participants consented, met the requirements, did the pre-survey, it was followed up by the distribution of my kits and then 2 online menstrual hygiene management classes. Phase 2, this is when the distribution happened and the participants used these menstruation kits and the knowledge that they had received. And then phase 2 was my post-intervention surveys. So total, we looked at a 120-day window. My participants were adolescent girls aged 10 through 19 living in Trichy and Trivandamai who were menstruating. The project included girls who had access to a computer or internet access because they had to watch the pre-recorded videos. They wanted to try reusable napkins and receive education. Exclusion criteria for this was inability to speak or read or understand English, pregnancy, inability to comprehend written materials, inability to physically care for oneself. And the sample size was 50 female adolescents. So my hope was to reach 50. I was working with my community partner, sewing back here, and I live in Canandaigua, Shortsville, New York, so upstate New York, and assembling all these pads, and 4 days later, I got a WhatsApp call from my community partner, and she said, okay, I got all 50. And I said, excuse me? She goes, yeah, we filled our enrollment in 4 days. I have 100 women that are also wanting to participate. Can we move the sample size to 150? And unfortunately, due to logistics, and the sewing time and the resources needed to produce these, I was unable to accommodate that request, but within 4 days, I had my sample. My measures, so we looked at demographic questions, age of onset of menstruation, religious affiliation, indoor plumbing, both at school and at home. The knowledge test, it was a 20-question multiple choice that looked at, can the participant define menstruation? Do they know what organs are involved? Hormones involved? Proper wiping practices, front to back, disposal of menstruation materials, symptoms that occur with menstruation. And then I also use what's called a modified version of a menstrual practice need scale, an MPNS 36 tool. So that tool, the MPNS 36, was developed by Julie Hennigan out of Hopkins. And I emailed her. I simply emailed her and I said, hi, Julie, you know, I'm looking at capturing menstrual hygiene needs. I know that you just did some work out of Uganda. You just published on it. May I use your tool in a modified version? And she hit me back immediately and said, absolutely, you're welcome to it. So I was very lucky that there was a standardized tool that I could use to capture this data. So the MPNS 36 is a 54-item tool that uses a Likert scale, and it's divided into 6 subscales. And it looks at material and home environment needs, transport and school environment needs, material reliability concerns, change in disposal insecurity, and then reuse insecurity. Because my participants were adolescents, and because some of them English was a second language, we decided to do a modified version and break down the number of questions to reduce participant burden. So we used this modified MPNS 36. We took it down to 31 questions. And in addition to those, we asked questions like, I was able to choose the materials that I wanted. I felt clean during my last period. That was really important for me to capture their perceived, their perception of menstrual hygiene health and how in control of the situation they were, and that they had choices. That was really important to me. So when I was working with my NGO, I was very lucky. I had a fabulous NGO that I worked with. They were in charge of collecting the participants, community outsourced and research, looking at the criteria for the QI project. They got verbal consent from my participants, pre-knowledge test, distribution of my kits, documentation that each participant had viewed the 2 PowerPoints, and then between the 4 to 6 week mark of the project, they checked in with my participants to make sure that they didn't have any questions, or if they needed any assistance with the cleaning and the drying of the reusables. And then they also collected my post-knowledge data. So for my data collection, again, 20-item test, we used the modified MPNS 36. They had a 90-day window for the intervention period, followed up by my post-questionnaire. My data collection was blind, so I do not know who these 50 participants are. They had a secure code that only the Agarwali Ambali Alex knows, and that was anonymous. So these are some of my favorite slides. This is my project in action. So on the left hand of your screen is Ambali working with some of my participants. And then on the left hand side, this is another group of girls that are being enrolled in my study. So you can see behind the girls on the right hand side, there's that white like 5-gallon bucket. Typically for females, if their father allowed or the head of the household allowed, they were allowed to use like a menstruation bucket or a bucket if they didn't have indoor plumbing. If not, they had to, walk to a safe or secure spot, both during the day, during the evening. And then we'll go through my slides quickly, but as you'll see, a lot of my participants had to do the same practice when they were at school because there was no indoor plumbing for females. So when I look at my results, I'm going to just kind of briefly walk you through these. The average age of my participant was 15 years old. Average age of onset was 13. All of my participants attended school. For religious beliefs, 30 identified as Hindu, 6 as Catholic, and then the other 14 chose not to respond for their religious affiliation. 46% of my participants had running water in their home, and then 40 participants had them at school. When we start getting into my knowledge test, briefly we'll go over to the right side of the screen and just look at our paired t-test value. But average knowledge went up by almost 4 points on their test. When we look at material and home environment needs, we saw great growth there, that the girls felt more comfortable managing their menstruation at home. Transport and school environment needs, we didn't see anything significant there, but that's not uncommon because there's no toilets or facilities or privacy built into the schools. Material reliability concerns, again, we saw growth there. Reuse needs, we saw that there was a decrease burden for my participants about where they're going to get their next supply of reusable sanitary napkins or any absorbent material. And reuse security, we also saw growth there. When we looked at the 2 questions, I was most able to choose my menstrual material needs that I wanted. 0%, we didn't see a change. These females don't have the option to say, you know what, I want to use a vaginal cup, or I want to use tampons, or I want to use, napkins, or I want to use reusables. They don't have the option. They are left to whatever they can find. And a lot of times that's unsafe practices. Some of the research suggests that they use like newspapers, old clothing. There are different programs set up in India that they give them disposable sanitary napkins, but they're of poor quality. The girls don't like them. They leak, but they're really at the mercy of whatever they can find. In question 2, I felt clean during my last period. Once we started using the reusables, we saw significant growth there. Again, this is a slide that just looks at what they used previously to what they use now. I had a 100% practice change, so every one of my participants, regardless of what they were using before, they adopted the practice of these reusable sanitary napkins that we had introduced them to. And I think the most significant thing here, one of my aims, was looking at missed days of school. And we saw a significant improvement in missed days of school due to menstruation. So at the end, 90% of my girls had not missed any school due to menstruation. So that was significant. These are the knowledge test questions. I've highlighted the ones in red where we saw the most significant growth. Prior to this, only 46% knew what menstruation was. Afterwards, 82% did. They were able to identify the hormones. After going to the bathroom, they knew to wipe from front to back. They were aware of what ovulation was now. They could identify symptoms of urinary tract infections, symptoms of yeast infections, among other things. So lessons learned, I think this is a really important slide. COVID ended up turning into an advantage for me, believe it or not. So the advantage was all participants received the same information. They all listened to my voice, my pre-recorded PowerPoints. Due to the enrollment process, we were able to capture girls without internet access. So this became a really rich sample size. So my auger Wally would go into the community and she would take her iPad with her, and then she would turn her iPhone into a hotspot. So I was able to capture girls that had no indoor plumbing, no access to internet, and they were able to listen to her iPad into the pre-recorded lectures. And so I feel like that really helped with a rich sample size and a diverse population. Built-in recruitment allowed for us to meet our sample size, right? So we met that in 4 days. Disadvantages was increased time burden on the staff in India. I had planned to do most of it on my own, so I had to heavily rely on my NGO. Cost of shipping the materials to India was approximately $800 US to get my materials there. I had originally planned to put them in my suitcase. Customs in India, again, my whole project was in one box being held up in Indian customs. And then there's a 10.5-hour time difference. So anytime that we wanted to do a Zoom call or a WhatsApp, we really had to plan logistically when those conversations and interactions between our communication would take place. This is my most favorite slide. So this is my participant feedback. Again, I've never met these girls, but this is what they had to say. The girls showed great enthusiasm and interest. The study helps the girls understand better about their menstrual hygiene. We feel very happy that we can go to school without being absent during our periods. They don't feel looked down upon by boys. The drying shields are very much liked by the girls. And then my favorite, we feel honored, we feel comfortable, and we feel happy to be a girl. So, that wasn't one of my original aims, but it was definitely amazing feedback that I got from this project. So looking at future studies. So next January, I plan to unblind the study, and we're going to do a follow-up with the 50 participants. And we are going to look at, are they still enrolled in school? Are they still using the product? And did they graduate from school? And I'm also going to work with a top economist to put a financial price point on this, right? So what is the financial implications to the country as a whole if we keep women in school, they get an education, and they're allowed to move on to college? Utilization of the sewing room. So they have a female group in Trichy, and I would like to eventually transition this project from a US-based project to an India-based project and give them my samples so they can recreate these reusable napkins within their communities. I've been asked to run this study again, this project again in Ethiopia with the same NGO partner. And I'm also in talks with Carmelite nuns that run all women's schools in India, and partnering with the Carmelite nuns and using these reusable sanitary napkins. So a lot of cool things coming down the pipe. I was recently published. So this was Reusable Sanitary Napkins in Rural India, a remote quality improvement project. So my doctoral thesis was published in this journal. It just came out in 4 languages. I believe it's English, Spanish, German, and French, I think. And I've gotten some really good feedback, and other institutions that also are looking at reusables, enrollment, education, empowering young women, and how do we put this in their hands. And then these are my references. So I will go ahead and take any questions if you have them. This is a passion of mine. I'm very happy to talk about it. So I welcome any feedback or questions.
All right, I'm not seeing any questions in the chat, Samantha, but from eBoard over here, we're wondering what the cost per package is for your menstrual kits.
Yes, so US cost estimated I believe I spent close to like $1,500 on the mesh pennies and all of the supplies needed to produce them. So if I had to guess, it's about $10 American per package to send them, $10. But that does not include the time that it took to sew them. So combined between my grandmother and I, we had about 400 hours of sewing time. So if I had to pay somebody to reproduce these on a larger scale, obviously you would have to factor that cost in.
Wow, thank you so much. That's really impactful, all of your work you're doing, and we appreciate your presentation today. So if nobody else has any questions, I just want to again thank you so much. And if anybody else from the conference does, we can send those to Samantha, or you can send them directly.
I think I have one more question. So there was a question that the pads are reusable. Is water access an issue? And yes, water is an issue. So a lot of the girls that don't have access to water, the design of the napkin is foldable. So if you take the napkin, it folds into itself. So it doesn't make a mess in their backpack or their bag or their purse. And so they can keep them in there and it keeps it somewhat clean. And then when they have access to water, they can bring with their laundry, they can boil the water and wash them from there. So that was part of the design for the original napkins, that they were self-containing to cut down on the mess and for them to be able to wash them.
Awesome. Thank you so much, Samantha. So I just wanted to take this opportunity to talk real quick about an event that we have at GHA that is related to what you're doing. So hopefully you guys can see my screen here. We have a volunteering event coming up on Saturday, April 2nd, where we will also be sewing and assembling reusable menstrual kits. So we work with an organization who does work similar to you called Days for Girls. And we had a very successful event last semester. We had about 50 to 60 students come out and help us, and we assembled lots of kits. So for any students or RIT staff and faculty on this call, we would love, excuse me, to have you guys join us this semester. So thank you very much, Samantha.
Absolutely. Thank you for having me.
All right. Yes, thank you very much. And it was very serendipitous that your research corresponds very nicely with something that we've been engaged with as well. I had a great time when helping last fall. I was sweating bullets when they put me on a serger and I had to like sew things, and I was just praying that my grandfather, who was a tailor's DNA, was within me somewhere helping me make these kits appropriately. So so thank you for joining us. It's great to have colleagues from Lemoyne on the conference. All right, well, take care. We're gonna go right on to our next presenter, who's a friend, Dr. Rachel Mcginnis. She focuses on things that are very tough and challenging. I know she's held her own conferences regarding like the sort of ravages of war and sexual violence during times of conflict and different things like that. Certainly, I'm thinking that what's going on in the world right now with the atrocities happening in Ukraine and more than maybe 10 million displaced people and millions of refugees and whatnot, that's the kind of stuff that Rachel has dealt with over the years. Now, she is in a really tricky situation where she's going to be presenting to us from an unusual location because she's supporting a family member who's at the hospital right now. So I appreciate her hanging in there and giving it a go. So Rachel, are you all set? You can share your screen, I believe. We've made you a co-host. Hopefully. Yeah, there you are. Not sure we have your audio. Are you speaking at all?
Can you hear me?
Oh, starting to get you now. Yep.
Okay, great. So there's going to be, my presentation is going to be a little bit untraditional, just in the fact that I think that for a lot of the topics we're discussing today, we are aware of these, or they are very much have been talked about in society. I traditionally work with a population that is often disenfranchised and not always even acknowledge that it's an issue. So I'm going to kind of use the presentation, but I'm also going to kind of give you like my own overall view of looking at things, kind of to give you some background and some insight into the bigger picture. So I'll start just to let you know, my name is Dr. Rachel Mcginnis. I was at RIT for many years. I started out, did my bachelor's, my master's, and then went away, did my PhD. While I was doing my PhD, I spent some time in Lebanon working with individuals, and that's basically what I've done for the last 10 years is work with the forcefully displaced population. People that are either internally or externally displaced, usually due to conflict, but sometimes even environmental issues like drought, things like that. So what I originally started doing in my undergrad and even my master's was looking at sexual assault as a military tactic. At that time, looking at historically what had happened in the Balkans, what had happened in Rwanda, even with the Holocaust. And during that time, you begin to notice that there's sort of this elephant in the room, right? If what we know about sexual assault is that it is about so many things to unpack, and gender definitely has a place at the table, but it's also about, you know, violence. It's about power. It's about rage. It's about control, all of these constructs. And if that were the case, then it couldn't just be something that happened to one gender. And so I started looking at, is it possible that we've had sexual assault survivors throughout these conflicts? And once you open the box, you realize that we go all the way back to ancient Greek and Roman times where there's laws and legality actually on the books stating that if a male is assaulted during conflict, he cannot be penalized and he actually needs to be compensated for the lands or for whatever loss he had during that conflict. To me, that was a huge moment because that's kind of, it's kind of like an aha. You get this idea of if it's that significant that they were putting laws on the book, it must have been something that was happening in a very likelihood, a very common aspect. So we start all the way back there. And if you look at it, we have conflicts all the way through time that kind of look at where we've had sexual assault, right? So going all the way there to this is the last 50 years of the conflicts that we are seeing and the issues that where we have had documentation of some form of sexual abuse, sexual violence against males specifically. If you look at it, encompasses almost every conflict that we've talked about since the 1970s. And so we look at it currently, both Syria on both sides of the conflict, right? We have looked at basically, we call them Daesh, but ISIS is what they were better known at. We see it being used similar to what we've seen in different organizations around the world, and maybe gang initiation, things like that. It would be like a form of jumping in. It would be a form of initiating soldiers that were not part of the region to bring them into the group. It was also a way for them to also control prisoners that they took at the time. In addition to that, we also saw it with Assad, using it over and over again, and this has been documented by the Human Rights Watch. It's been documented by the UN, where we've seen that Assad has used sexual violence against males, against what they would have in terms of prisoners. And prison could be anything from your neighborhood that you were talking to, that you were a spy, to you took a loaf of bread. It runs the gamut. So we've seen it there. Another current one, the Central Republic of Africa, they have, it's been used quite a bit in terms of Boko Haram and different groups there, but again, used again also as the government. And now, I mean, we've had a report as recent as this week detailing how soldiers are going into the houses and sexually assaulting whole families at a time. This is still developing. This hasn't been vetted, but there are multiple sources that are discussing this, and this is not something that hasn't been used historically with conflict in Ukraine. So it definitely has a place at the table in terms of discussion. So those are where we're looking at right now, which is a huge area to cover, a lot for us to look at. And honestly, we really don't look at Guantanamo Bay as a form of conflict, but it definitely has a place at the table. It was one of 4 case studies in my dissertation. So I think that deserves a note in and of itself, that the United States has used their own methods in terms of this. So what are some of the issues? Why do we see this, and what does it look like? This is something that runs kind of across the board. It is different during conflict, but it is something that we see consistently, even here in the United States. But especially in conflict, if you look what we're seeing, what I hear oftentimes, I work with individuals in the refugee camps or in the conflict zones. And so we have people that come from communities where males are dominant, they are perpetrators, they are not victims, right? The idea that there's a big belief in many of these communities that men cannot be sexually abused, which has been repeatedly not proved. It's been repeatedly proved, been an issue that is one of the major hurdles that has to begin rated, that we have right at the beginning. And the reason for this is that a lot of times they will say, well, arousal equals consent. So if someone is abused and they had a form of arousal, obviously they wanted to engage in this act. Again, we know this is not accurate, right? We know this is not true. Arousal is sometimes it's demonstrated in terms of like flight or fight. There is a term of fear. It doesn't necessarily mean just because a male is present doesn't mean that he is willing to perform. Another issue that we have is in 70% of these countries where 66 to 70% of the countries where we see sexual assault right now during conflict is in countries where homosexuality is still a crime. So in many ways, this is a perfect way to kind of get away with this, right? You can't go to, you can't report this to anyone. You can't go to the police. You can't go to anyone, because if you do, then you're possibly charged with the crime of homosexuality, and you could actually go to jail. So this often keeps male victims quiet. It often keeps them kind of re-victimized in their own ways. Another is that there's a strong belief in these communities that if somebody's sexually abused, now they're going to be people that sexually abuse themselves. This is 2 or 3 times more likely than what we see in terms of the belief with females. But for some reason, there's this connection that males, if they are sexually assaulted, they will become perpetrators themselves. And then the idea, again, right? Boys don't cry, men toughen up. So the trauma is not as significant in males, that they can deal with it. That it's really not as much of an issue, that it's not something that they have that's truly problematic. The girls are more emotional, that it has a deeper impact on them. So before we even begin working with doctors, nurses, people on triage, things like that, we have to kind of sit down and unpack all these conversations, which is really a difficult thing to do because we're talking about decades and hundreds upon thousands of years built within these communities of this mentality. So not only do we have to do it for them, we often have to do it for the victim themselves, right? So when we have individuals coming in, you'll often hear, and you'll see this in the reports, you'll see this in when Human Rights Watch or anyone does a documentation for women, they will often, and this is not, I don't want to give a blanket expression or kind of like one size fits all, but in general, what we see is that women are more likely to talk about it early. They're more likely to report, maybe not to a actual facility, but to another member in the family. And they tend to begin working through it in a very short term, at least working through it in terms of trying to process it and move forward. With males, they tend to not talk to others. they tend to internalize, and they tend to not disclose that they've been sexually assaulted, generally to about 2 decades after they've been assaulted. And so what we see there is often there will be something that's a transitional, right? So if you're sexually assaulted as a male as a child, maybe becoming an adult, you now feel safe enough that you may be able to talk about it. But they are very much consistent with the conversation either comes where they feel they are moved further enough away from the perpetrator, or they have found a way that they can, at least they believe that they can prevent something like that from happening again. And that's a big issue, because when it comes to identifying your symptoms, when you come into especially into the refugee camps, it's very difficult, because even in these communities, a lot of times the females will be shy, not shy is the wrong word, but will be maybe a little bit slower about coming forward, are much more private. The gentlemen will share symptoms, but they won't share what happens. So you're constantly kind of like trying to pull this information out. You're constantly trying to reframe. And you will see even the way that people that have faced war crimes or have human rights violations will explain it. Women will share and talk about the fact that they've been sexually assaulted, whereas with males, they will say that they were tortured, right? They will not give an indication that there was some form of sexual assault. They will have it, they will use the words torture or abuse or things like that, but never in a sexual connotation. So just all these things to begin with are what we're unpacking before we can ever even start to begin to help the victim, but also help the resources of the individuals that are in the community. And this is critical because it's imperative that we have the right tools to begin with, and having these tools is actually building all of this from the ground up. So the big thing is that what we want to look at, right, is kind of identifying these differences that we talked about, and kind of seeing like where we need to unpack and go with these things. And one of the things we need to do is kind of give this ideology, not only in conflict zones, but also here in the US, is that deal with the fact that it is okay for males to receive help. It is okay for them to be assisted, that it's not a sign of weakness or a sign that you cannot protect or take care of yourself. What we see again in this research and in these studies is that males oftentimes, especially in certain communities, we have a more negative attitude towards receiving that help and assistance. They feel like it should be there for children, for women, but not for the men themselves. And this trickles down to even the way that help is distributed, right? So we have, like in the camps, for example, males are the last ones to receive assistance. It makes sense, right? You take care of women, and the women and children, you get them placed. But this also leaves young men and boys oftentimes more likely to be susceptible to trafficking. And we're not just talking about sex trafficking here. We're also talking about organ trafficking, which is a huge issue. And it makes them more likely to be street kids, and it makes them less likely to be able to get education and resources that they need in order to survive. Like I talked about, they're less likely to report. The reporting average right now is about 20 years after the assaults have happened. Again, we talk about emotion-focused therapy, which historically has worked really well in terms of working in the different camps and having the discussions. Men have not responded as well to this, and so it's required us to be very resourceful and creative in terms of the way that we approach this. They often see it as a threat to their identity, right? As male, is that, they're talking about their feelings, things like that. So what we have started using, which is a very unique, interesting thing, is the form of music, the form of art, specifically. Having them music is a very intricate part of a lot of the forcefully displaced populations' cultures. And so this does allow them a way of communicating without necessarily communicating, because a lot of times the imagery is abstract. And so it's left open to interpretation. It allows them to share what they're going through without necessarily identifying what their experience was. And then seeking help is definitely a direct conflict, right, with their societal norms. And we see this from all the way to the very beginning to big issues like healthcare and things like that, to minimal things in terms of like just food and water and things like that. So if you look at the way that the exodus during the Syrian conflict happened, and what has happened traditionally in a lot of conflicts, is that basically what happens is that the one primary male member will be sent first to someplace, whether it's Greece or Germany or wherever, trying to make sure that someplace is safe for their family to go. And then they will send an uncle, the mom, and usually the daughters, and then the son is usually the last one that gets to come. He usually is the one that closes up the house, and he comes afterwards. What happened with the EU-Turkey deal and the issues from that is that this often left people kind of closed on both sides of this deal, right? We had a lot of young men who were stuck in Turkey, who were stuck in Lesbos or Moria in Greece, not allowed into the EU, while their families were already settled on the other side. Because these young men often are taught not to ask for help, or they created like their own little groups, and you will see large communities, whether you're working in Rome or Sicily or one of the islands, whether you're in Marseille in France, whether you're in Athens, Greece, or one of the islands, you will see these kind of small packs of young men and boys ages 8 to maybe 22. They've created these small families because, one, they're not as likely to ask for help, and two, when they do, the same societal norms are often within Europe, and we see in the West, and we have X amount of resources, and those resources are tailored to a different gender and group. With Lebanon and Jordan, where this report is coming from, it's a little bit different. They have been dealing with the outpour of refugees. Lebanon has, a significant amount of their population is Palestinian refugees to begin with. So that is, they already have constructs, so it's a little bit different there. But for Europe, especially Italy and Greece, this was all new to them, and this has created a unique dynamic that I think we're going to just start seeing the repercussions of now that we have had the conflict in Syria for so long and the outpour of Afghan refugees. So that leads us to the last point, right, that basically tend to talk about the higher, report a higher rate of lack of support. This idea that, again, like we talked about, not only are they not reporting, but then when they do report, they feel like they don't identify, they don't feel like they have anyone to turn to. And a big thing that came out of the study is that they take it very, very literal, right? So when they go, and if there is support services for people that have been assaulted or abused, they often say Women's Center. Or if there's support services, it'll say something in terms of women and children. Because that word male is not there, or because it doesn't seem overarching, they will never even think that it's possible for them to access resources there. So just the naming of organizations and the assistance that comes with it is problematic in with itself. And so that's where we kind of have to even look at, as we approach these programs, as we name them, as we create them, we really have a responsibility just to be mindful of that in and of itself. And so why is this so important? Why is this my focus? I think it's critical to understand the fact that this has resulted in transgenerational trauma. As we know, going back at research with the Holocaust and then survivors of the Holocaust, trauma that our parents and our grandparents faced is not even necessarily communicated through societal constructs, but also through our body, and that impact is going to have a significant effect, and we're seeing that now. As I said, we have individuals that now have been 20, 30 years traumatized and re-traumatized. Although Afghans are not classified as refugees by the UN, they still have been in transition easily, for quite a long time. When we first were in Afghanistan and there was conflict there, they were forced out a lot, and they went to Iran, right? So that they went to Iran, then the conflict was, then they were told that things were becoming better, they could come back home. Then the conflict with Syria heated up. Iran wanted them to participate in that conflict in Syria. Many of the Afghans then returned home, found that it wasn't safe. And that's why you saw the mass exodus of Afghans during the Syrian conflict into Greece, into other places. So it wasn't just what we were thinking in terms of traditional Syrian refugees. We also see a plethora, a large dynamic and number of Afghan refugees on top of Iraqi as well as others. And so we're talking about now children of children who are seeing this trauma of not only war and conflict, but a lot of times facing very serious situations where there's not significant mental health capacity to deal with, and definitely not funding. So the one thing that I have worked on, and I feel we have been somewhat successful for, is in 2014, the language from the UN was highly based on the fact that it focused on, its wording had women and children in about 98% of the documentation. When there, in 2016, that was updated and it became much more unified, but it still didn't mention boys and men. It didn't mention males. And it often, when it did mention anything that was gender identifying, it talked about pregnancy. It talked about things that were in a very female focused lens. So in 2017 and 2018, I worked with the EU to change the language of within the EU originally before it went to the UN. And the EU actually changed the way that they identify. They earmarked funding for male and boy refugees for the first time ever. And they identified creating specific shelters for boys and men that were sexually assaulted, that were at risk for being human trafficked, or were school age and not receiving academic services. So that's, for that to happen in a short period of time is a huge change. It kind of unpacked services that were missing, but also unpacked what people were seeing in terms of the idea of, to unpack the constructs of society, not just of the people providing the services, but for the victims of themselves. So that is the last thing that I do want to share with you, is kind of to give you one more tool that we have started utilizing in terms of helping refugees who are maybe not to that point of talking about looking at going to maybe a treatment center, going to a facility, talking to workers within the camps or the area. This is something that every individual would have access to. And the reason why I say that is because a lot of times when individuals leave their home, they don't know that they're leaving, right? It happens very quickly. They are not aware. They may leave in the middle of the night. And so they have very little on their body when they leave. The one thing they do hold on to is the fact that they have, they almost always have, in terms of, I'm so sorry, they talk about it in terms of they keep a phone. And why do they keep a phone? Because it's the one thing that keeps them having contact to where they came from, to the idea of it gives them a contact to who they're trying to get to, right? So what we did is we created a mobile phone app that's translated into 10 different languages now, that looks like a fully functioning calculator. But when you break that down and you open it up, it's actually what we call a skin. And so it's a mask. When you go in, you put your password into the calculator, and it allows people to access services that within their community. So there's 4 tiers to it. There's sexual violence, there's abuse, there's trafficking, and there is what we, a 4th criteria of stalking, which is more for the US, but it can be used across the board. So this is kind of where we're at. It's, like I said, it's in 10 different languages. It has been very, very helpful. I worked with the Special Rapporteur of Human Trafficking in Greece. That's equivalent to the FBI in Greece, to roll this out into the camps. It's been used in several other countries, and we've had a really, really good experience just getting it into the people. As we work on it and we try to get more funding, the idea is that it will be able to be customized. So right now it looks like a calculator, but the idea is eventually you could tailor it, right? So because eventually perpetrators will learn, right? They will find out about these resources. So the idea is that you would be able to customize it. So if you're really into FIFA, if you're a big soccer fan, it would look like a soccer app if you looked. And so that way, this allows you, again, another level of anonymity, and it allows you to have access to resources in real time in your own language with a direct access to, if you're not comfortable with the police, it gives you direct access to counselors in the area, how to get to those locations via bus, via walking, via driving. And it really has, in my opinion, has been a game changer. The last thing I wanted to do, and I'm not sure, Ava, I know I uploaded it on the drive. I was going to try to share and show the app itself so it kind of can give a better idea, but I'm not really sure if I have time to do that or if I can.
Hi, Dr. McGinnis.
Yes.
We have a couple questions for you that have popped up in the chat.
Okay. Sorry.
Okay. One of the first questions that popped up was from a participant that asked, or they mentioned that it's very difficult to understand the connection between arousal and violence, and do you talk about how attackers use sex? The same participant also asked, have you talked with sexual predators about how this happens?
So for me, primarily there's 2 different areas here that we approach, right? One is what we see in non-conflict situations, and one where we see directly as a result of a military strategy, right? So it usually has one of 3 different ways to kind of approach this, right? One, it's an indirect military initiative, kind of what we saw in Bosnia, with more of the situation with female victims, but definitely something that's been used. We saw it definitely during, in terms of Rwanda, and even the outpouring in Uganda in the camps, where we it was never a direct military initiative, but it was definitely communicated that this was acceptable and this was okay and this needed to happen. And why do we think this came about? Is the idea is that within, global jurisdiction, we have a hard enough time holding somebody accountable for genocide. It rarely, if never, happens. It takes forever to get someone brought up on war crimes. And so the idea is that is very, very difficult for that to happen, but it's still very rare. But on top of that, that's with mass slaughter. That's with bodies and with evidence. If you are sexually assaulting a male, or you're sexually assaulting another individual in a community where homosexuality is a crime, you have created almost a perfect war crime, right? You have someone that's never going to come forward and report you, because if they do, they can go to jail. Or they're never going to come forward and report you because homosexuality it's even if you're a victim, it's considered a form of homosexuality within those communities. So I think that's very, very interesting. I think that has a big component of how we deal with it. We have not gone on the opposite end and talked to people that have been perpetrators or aggressors of this act, and that's mainly because we have so much that we're trying to accomplish in terms of helping the victims and survivors, and it has been really more of a focus providing something that's hands-on, tangible, versus something that that we've been research focused in terms of the perpetrators. Does that help? Does that answer the question?
Yes, thank you so much. And another question that had come up was from a person that was interested in learning more about a term you had used earlier on in your presentation called organ trafficking. Could you briefly explain that?
Yeah, so the numbers fluctuate somewhat depending on what resource you use, who you talk to, what area of the world you're looking at. But when we look at areas of not even just post-genocide or post-conflict, but during that time, when we look at trafficking, the numbers are significant. And during those trafficking, they're broke down in very interesting ways. And one area that's highly ignored, and you can see the number as low as 1%, you can see the percentage as high as 6%, is the area of organ trafficking, right? And this happens for a multitude of reasons. One, good, bad, right, or wrong, after there has been violence and conflict, there is a lot of bodies to pick from and harvest from, and this is big business. It's done quite frequently. People will go through after after a fight, especially something that there has been something where it's been quick and over and done with, and they will take the organs and harvest them. Another thing that we see is because these individuals are fleeing homes with, even if they have resources to begin with, the average individual, the average forcibly displaced person is about 2 generations. That's 2 generations. So if you ask most Palestinians that are in